Uh, so good evening, everybody. So we'll invite our patron, Professor Subrat Acharya, to start the session 6 of GLAD. Professor Acharya, please.
Good evening, friends, and hearty welcome to the sixth GLAD session on continuous medical education, which it is actually which is being held every month in the last Friday in the night from 8:30, and 5 sessions has been already been held, and this session is very interesting topic actually. And this is a very practical topic and many times a real life scenario for many physicians as well as patients. And quite frequently it is encountered. And this is about the end-stage liver disease patients where there is no medical therapy is available and liver transplant is only the option. But transplant is a therapy, but the timing of transplant is vital actually for the outcome. And when the patient is subjected to a transplant at the right time, the benefit is maximum. And that's why that is a very tricky area and fairly ignored in our day-to-day life. And today, I'm very happy that such a very tricky yet practical area where the knowledge is very limited and is widespread. It is very limited, has been chosen. And none other than Dr. Ashok Chowdhury, whom you know is the founder and actually he's the mover and shaker behind the whole GLAD and whole process, and he will speak on it. So Dr. Chowdhury, start the ball rolling. Without wasting time, I will invite you to start telling us about it.
Thank you, sir, for your nice introduction. This is our sixth session. So today we are going to have a more practical aspect, as rightly said by Professor Acharya, going to refer for the liver transplant. You can see liver transplant is one when a person is giving, and another one when a organ has been harvested, that is called as a organ donation from the cadaver. And when we go for this, what happens? It, as rightly said, it is life-saving. It improves the quality of life, and overall outcome is improved. And many people fear that transplant is not having successful or it is short-lasting. This is a very interesting study of large populations where they have been compared for 25 years. You can see the 25 survival. This curve age up to age of below 15 years, and this is above 15 years. And the transplant survival is close to 60% at 25 years. And it is also same for the adult also. So with improvement in science, with improvement in technology, the transplant and the outcome is encouraging and also long-lasting. So when a person gets a liver injury, he may develop liver failure, we call that ALF. If he is having some chronic disease, no symptoms, he develops ACLF. If he is a cirrhosis, he develops decompensation or progressive end-stage liver disease. So how a chronic liver disease happens? We first see these people to be compensated, then they develop complications we call as decompensated, and a stage comes where there is no recovery from this decompensation, that is called as end-stage liver disease. So in this group of patients, we get features like varicose bleed, they develop ascites, they develop hepatic encephalopathy, they develop hepatopulmonary syndrome, they develop portopulmonary hypertension. These are related to portal pressure. And at the same time, the liver function is impaired, they develop jaundice, they develop coagulopathy, ascites is there, they develop confusion, altered syndrome of the liver coma, hepatic encephalopathy, liver impairment, that is hepatorenal syndrome, infection spontaneously, that is spontaneous bacterial peritonitis or spontaneous bacterial empyema in the pleural fluid. So now when a person comes to you with a liver failure, be it acute, be it ACLF or be it cirrhosis. So now we have to know when to refer for the transplant. So the first thing we discuss is acute liver failure. Acute liver failure is a condition, is a catastrophic condition where the liver injury happens in relation to an acute insult, viral hepatitis in India, particularly hepatitis E and hepatitis B, and then because of this, some drugs, complementary alternative medications, where the liver fails. And this is considered as a triple criteria, that is jaundice. They will have jaundice, they will have coagulopathy, and they develop alternative hepatic encephalopathy. So in this group patients, when you see in a clinical practice that they have suddenly have altered sensorium or confusion, his blood parameters are going on. So we have to see three things. First is the bilirubin. So when the bilirubin is rising, or they develop coagulopathy, that is PT-INR is rising, or they develop confusion, hepatic encephalopathy. These three parameters gives a signal that this person is having acute liver failure, which is called as the liver emergency. This condition, we need some parameter of having a blood gas analysis if it is possible. It is INR, it is sodium, it is having confusion, it is having bilirubin around 17, and if possible ultrasound in your area is having the liver size is shrunken. If these are the conditions are available, any three of these indicates that we should refer this patient for the transplant. But as a physician there, you should do when you find a patient like this, you have to find the cause, search for them. You just monitor their three parameters, most commonly the PT-INR, the lactate, and the ammonia. If these facilities are available and these parameters are on the higher side, it is an alert signal and should transfer them patient to a nearby facility with specialized units. In the same time, any altered behavior in a patient of acute liver failure is considered as hepatic encephalopathy, and we should not allow the patients of liver failure should reach this stage. They should be immediately referred, because ALF is hepatic emergency, and most common cause for death in this group is infection, cerebral edema, and persistent progressive liver failures. So, as a physician, you are smart, you are alert, and you have to think these patients how we can improve the outcome. So, you should first think that if you diagnose ALF, we need to transfer these patients or refer these patients, because treatment is mostly specialized or quaternary level care. And we need to refer these patients before they develop hepatic encephalopathy, because if it is hepatic encephalopathy, it correlates to the cerebral edema, and more delay in transfer is risk during transportation, because any movement of their body leads to cerebral herniation, and which make them into vegetative state, or these patients may not improve with any possible therapy. And for this, what we need to know, we need that it is urgency, the transplant is need, you should have to be convinced, as well as we have to counsel the relatives, and we have to tell that this is a need a emergency liver transplant. And when this patient has been referred, there is a very minimum time, we should have to tell them about the donors also, because they need a transplant with a period of 24 to 72 hours. So this is when we discuss about the acute condition that is called as the liver emergency, AL, acute liver failure or ALF. Similarly, when a patient comes with having some chronic liver disease, they, because of alcohol, because of hepatitis B, because of hepatitis A and hepatitis C, they have a autoimmune disease, they take some drugs, it is a Wilson's disease, they develop liver failure. This present as jaundice, they develop coagulopathy, they develop ascites or hepatic encephalopathy, but it is not so rapid. It is slowly a period of 1 month, and hence these persons are called as ACLF. And this group of patients, 23% in 142, 51% die of this course is pretty much rapidly progressive. As you can see here, that this group has become very much fragile, and when they become fragile, it be very poor outcome. Then we have few scores. The score we use them to predict. It is very simple parameters like bilirubin, which is available with you, hepatic encephalopathy, which is available with you, INR is with you, lactate in the blood parameters, and creatinine in the blood test. So when all these are there, you can refer the patients if the score is more than 10 or 11. These are calculators available to MELD score. You should refer these patients for the transplant, and those having below this 10, they should be referred because they need a advanced care. So, because these patients are need to be reported, they progress very much rapidly. So, what we have discussed, if a person of SLF has diagnosed, this should be referred early to be managed with a specialist field. The score, if possible, we should think that R score should be more than 10. MELD score is also available, it's 30. And this patient is not improving within 7 days, then they should be counseled, or any grade of confusion, altered sensation, or hepatic encephalopathy, they should counsel. So these persons are sick enough, hence in these parameters, they should be shifted. So, not intelligent clinicians, we need to diagnose them. We need to have this treatment. We see these people for 7 days. However, this first 7 days and improvement of the disease need counsel treatment. This need of a transplant. We need for urgency, and at the same time, majority of cases are
No.
Ashok, we can't hear you, Ashok.
am I audible now?
Yes.
Yeah,
We can
screen
hear
is
you.
visible. Sorry.
Yes,
So now
you can
when
hear.
we saw that this is the group of the patients, now most important comes to us the cirrhosis. The major chunk of people with us are the cirrhosis. The cirrhosis, when it is there, we have discussed these complications. Any person of cirrhosis comes to you, if he is compensated, their survival is close to 10 years. But suddenly they develop any decompensation, as we discussed, the survival is close to median survival. That means 50% may survive up to 2 years. If they develop ascitic fluid infection, the survival will be less than 1 year. If refractory ascitic, it is 6 months to 1 year. If they develop renal failure, it is less than months. And simple way, when a person you have seen with varices as a cirrhotic, mortality is only 3%. But once they develop ascites, this mortality in 1 year may be 20%. If they develop ascites along with varicose bleed, the mortality is close to 60%. So you have to remember that if you are seeing a patient of cirrhosis, you are following them, have any of these complications, it has its own notion, and when they develop complications, they need to be considered early for the transplant. So though, as we discussed, the most commonly the present is ascites. If this ascites is refractory, that means they require tapping at least 2 or more times in 3 months. If they develop fluid, if they develop persistent thin and these peoples are immediately should be considered the referred to a transplant physician. And has been diagnosed its implications discussed. If it is persistent or it is being a recurrent episode, then it is a more severe transplant. Another group of patients in this who are being confusion, slowness, forgetfulness, with them how to go for this group of patients, how to go for. So, network problems. So this is we have discussed as hepatic encephalopathy. So after the hepatic encephalopathy, the next is the varicose bleed. The any person develop first bleed, there may be controllable or manageable. If they develop recurrent bleed, severe refractory bleed, or other sites, it causes more risk as far as the concern for the outcome is concerned. Then, as we discussed, the liver synthetic function is defined as MELD score is 15 or more, CTP is 8 or more, presence of jaundice, hepatic encephalopathy or coagulopathy. These people need to be considered the active as far as referral is concerned very early. Then, important one is the liver is simple notion can 70% or lead to downstairs disease. So any person comes to us if we can, that is so. So this will be counted for this will be counted for evaluation. Sorry, apologies for my net. And we need to see that what implications. These are very few common models which we can use at our peripheral setup, like MELD failures. So consider most common one, that is the child score. So child score we discuss is very common parameters. Said to be used, and also now the app has been developed. So if a person is
We lost you, Ashok.
sorry, the patients. If you are coming, you have just a simple mobile app. You can calculate and can grade them as child ABC, and this makes a consideration for referral at the earliest possible. Similarly, if the score is higher side, the shorter score is 9, the mortality may be 4%, whereas 3 months mortality to 12 is 40%. So a person, if you see in your clinic, is having concept to be having a child C, the survival is as very much poor as such, and if scores there on the side, to refer them for the transplant should go for, because in 3 months the mortality will go very. So sorry again lost. So score will help as you can see here as per the values. Then important parameter wise is SCC and few other indications where you get poor quality of life, like polycystic liver disease, severe pruritus, recurrent cholangitis, or uncontrolled fatigue. They are the few conditions where they need even the male objective score is not on the higher sides. So here we discuss few urgent indications. We already discussed this acute liver failure one condition and other conditions after. How to go for, sorry, this is the minimal listing criteria where we see and proceed. And you can see a person if has developed any decompensation, a child score of 7 or above, if SBP, if refractory ascites, encephalopathy, SCC, or to discuss dysfunctions previously, any parameters are there, this patient should be considered advised for the liver transplant. So Now question comes, is it the timing? As rightly said from the beginning by Professor Acharya, the timing is most important, because if you are waiting for these patients, the patients become sarcopenic, they become frail, and the outcome will be poor. The disease severity score goes rising, that makes the transplant more difficult. If there is some kidney derangement, they may progress to is there, they may progress call for how to go for in this group of the patients. So it is the timing, and sometimes it is the sepsis or bleed has make a toll also. And very time we get a discussion about the financial aspects, and you can see the direct expense and indirect expense. A person if need if they delay or we do wait for them, the direct expense on continued care goes on despite this transplant. Being a sick enough or with complications, prolonged course make the outcome more poor and the financial burden will be more. Sometimes the patient may not make it while you are delaying the plan, and direct indirect will make the transplant become much more expensive. Hence, it is first to decide when we need to transplant or no. If it is late, there is no question of delaying it. It is that is why the whole global consensus is now to identify that these patients need transplant or no. If transplant is needed, there is no more question of delaying. It is both European and American Society on the Liver, they suggested this. We have to know few contraindications, totally compensated stable cirrhosis, I want to say, and other things will be done by the transplant team. And transplant is mostly a indication, contraindications are to be decided, but for the referral for the patients, we need to know that all cirrhotics should be at the time to be saved and to survive. So just to summarize, there is a lot of interruptions in between. So I apologize for this presentation being some network issues. But the take-home message is that ALF or ACLF, they are considered as a severe disease, have an unexpected course. They should be referred immediately, whether they need a transplant or at a tertiary or quaternary level. Index doses needs all workup to know the etiology, know the disease severity, and likely plan of management. Cirrhosis with only decompensation is to be referred to a concerned gastroenterologist or hepatologist or the specialist person who is in this field. And we should consider transplant at the early. Once transplant is indicated, the delay or confusing decision will be a riskier one. In case of unavailability of a donor, if you want to go for a cadaver transplant, we need to refer very early at the beginning. And in possibility of live donor transplant, we need these patients to be closely monitored and referred sooner to get a better outcome. So this is what I want to say. Thanks everyone, and I apologize for the interruption, but we can have a discussion so that I can clarify any doubts are there. Thank you.
Thank you.
Thank you, Ashok. And I think there are other comments, and there are also chairperson who has their own comments to make. I request them to one after them to make other to make such comments.
Yeah, thank you, Ashok. It was beautifully presented. Some of the slides I could not see because connection was not good. But the whole message is very clear, and it is very important for every one of us, and especially the physicians. Always give the option to the patient about the possibility of the liver transplant, because sometimes it may happen that you are not given the option of the of the transplant. Then later on somebody may ask you the question about the family member. They can ask the question, why you did not give the option? Because that's what happened to me sometimes earlier. I thought that, okay, this patient cannot afford for transplant. So I was not talking about the transplant. And nowadays, it is a different story altogether. So somebody in the family or relative, they know about it. That's why it is important to tell the patient that there is the option of transplant, and always you plan as early as possible about the transplant. This is very important message, very important subject, and Dr. Osok has beautifully presented it. Thank you once again, Osok. Thank you.
Thank you, sir. Professor Akash Shukla is there. Sir, what is the most common hurdle you see in your practice when you think transplant, sir? And from a physician's perspective, what you want to get them?
So, Ashok, I think excellent lecture. I must congratulate you. Practically speaking, I think when the patients come to us and when we counsel them that they require a liver transplant, the biggest barrier which I face is a psychological barrier that this is such a major surgery, and I would not be, and whether it is going to be successful or not. I think that is the biggest apprehension which all these patients have. And then second thing comes the financial burden and the myths which are associated with it. So very often people feel that, okay, they have to remain in isolation after transplant in glasses, and they'll be completely isolated. They'll not be able to work normally. Forever they will be bedridden. So there are a lot of misconceptions and fear in the people's mind. And that is why they don't go for transplant. So I think a very clear message should be told to the patients that, and unless it is at every level of care, the same message goes on, the people will not go for transplant. If you just look at it, you have somebody who has come to you with decompensated cirrhosis, and he has got ascites which is requiring tapping, let's say, for example, decompensated cirrhosis. He is a low MELDer. The MELD score is not very high. So people think that, oh, MELD score is low, so he does not require a transplant. But if you calculate that what is his life expectancy, we know in refractory ascites it is average 6 months. So this patient, even if you give the best therapy, and on an average he's going to survive for 6 months. And during the 6 months, imagine the amount of money that he'll spend for those repeated tappings, for the albumin, for the midodrine. The other thing is, if you look at any other decompensation and you look at 5-year survival after any decompensation, then you look at the cost-benefit ratio of transplant versus medical therapy. The transplant obviously is far more beneficial. Here, one thing we have to still remember, that there are conditions where even if they come to us with decompensated cirrhosis, they may still improve. For example, autoimmune hepatitis, early decompensation, we know that with treatment, it is still reversible. Alcoholics, we know that you can still reverse them. So just presence of decomposition is not important. So you have to look at the etiology also. So look at the etiology. If it is not reversing, not reversible, patient has significant decompensation, and as you have very beautifully laid out the criteria, I think we use our judgment according to that and tell the patient that it is cost effective to do transplant rather than continuing medical therapy with much, much better outcomes. So the fear has to go away. We know today in our country that transplant success rate is more than 90% at all the major centers. I think the other beautiful thing is the excellent quality of life after liver transplant, because there is no HLA expression. So you require very minimal immunosuppression. You have most of the patients beyond 1 year are only on single anti-rejection drugs, and that too very often they're on once a day. So it's basically one pill a day, and the monthly cost doesn't come more than 2,000 to 3,000 rupees for most of these patients. So I think once these myths are broken and people become confident, We have people who work for 12 hours, 14 hours a day after liver transplant, work on the fields, they work on the, they go for salesmanship, every single profession. We have farmers who are doing farming after liver transplant. So all this is possible. So I think this message has to go down at every level to break this mental barrier. I think once the mental barrier is broken, everything else can be taken care of.
Professor Acharya sir, I think Dr. Akash has suggested that it is the mental barrier, but we think the general physicians or the physicians who are seeing these patients or they're in touch in their close circles are a major base. So what is your thought on this group of patients and our doctors fraternity, sir? Because if they referred one patient to Professor Subrat, that's it. Go for a transplant, he will come to you, listen to you, as well as he will carry the message from his GP so that he will get more convinced. So how we can bridge? So the GLAD has the main thinking that way. So how you get, sir?
Well, you, Akash probably, and Professor Goswami, and you probably have given fair details about the whole ball game. But well, right, all of you are very right that there are certain things, practical tips are in a patient whom you see who is in liver failure, and you described what are the types of liver failure and what are the causes of such types of liver failure, how to identify such liver failure, how to predict such liver failure, and when you predict that may be right time to send them for a liver transplant, why they should be sent for the liver transplant, and what benefit they will accrue out of that. You very well describe each aspect of it. There is nothing to add. But well, in a very practical manner, what you are discussing, when you refer a patient to a transplant, they are all physicians. You are addressing it to physicians. They should realize whether actually there is adequate medical treatment for the disease or not. And has it been tried enough and they are not working? Is it threatening his life? Is he now fit to be ambulatory and go for a transplant? Or he is very sick and he will not survive long, he should be immediately referred to a transplant. These are the 5 categories you described very well. And these are the practical way how to assess a patient. I think the standard common language is much better. To tell them these are the danger signals. When you see a patient of liver disease in general, you can identify liver disease, and these are the danger signals. And this danger signal threatens life, and when you see them, you send them to tertiary care. This is what you essentially do. That's the way I see in simple.
Of getting a little bit of information gathering on this. So we have conducted a small survey. I'll request Dr. Akash to show the survey, what he has conducted on these patients. We have met. Dr. Akash, please.
Is the slide visible, sir? And
yeah. Very much visible.
Okay, sir. Okay. So we did this short survey. I think we did it last time also. Our primary focus is to focus on physicians. We did get a better response from the physicians than last time that we did. So it was just 4 days because it was planned just over the weekend, and then we decided to do it prior to this program today. So we had 82 respondents, mostly males, mostly physicians who are in between 30 to 40 to 40 to 50 and some and more than 60 age groups. Specialty wise, if we break them down, if it's like, again, 50% is hepatologists and gastroenterologists, but this time we had an involvement of more physicians, surgeons, GPs, even anesthetists who participated in this. The regions, it was primarily from north, east, and south, sorrowfully very less from the northeastern part of this country, and I think we need to focus on that part. some responses from Bangladesh and Nepal. If you see the areas where they practice, again, it's mostly the survey was taken up by people from living in metropolitan cities and who are placed at medical colleges. So we'll see some of those results. It is a preliminary data of around 3 to 4 days of 82 survey respondents. So the first question was that, is a liver transplant facility available at your setup? So I think this is again driven by the respondent type, because there are hepatologists and gastroenterologists who had responded to it. And around 40% say, yes, it's available in my place of practice. But what's important is that, see, the referral criteria is still there. You have to refer it to outside your states in around a third of the patient. And it reaches a little high when you subdivide the survey into the non-gastrohepatologist population. So it goes up to 40%. So I think the respondents were from some places where they were having to refer from outside their states for the purpose of transplant. The next was, what percentage of patients with cirrhosis do you need liver transplant? I think this is interesting. Again, some sort of a referral bias or institutional bias that is there. It's around 29% has said that 10 to 30% of all their patients need liver transplant. And around 25% said up to 30 to 50% need liver transplant. I think this is driven by specialty-driven responses, because those would be coming to a referral center, and that's the cases that they would be seeing. But if we see it on the other part, if I try to subdivide it and do a small subgroup analysis in non-gastroenterology hepatologists, and if you take that, just only about 60% of them say that less than 10% of the entire cirrhosis population that they see are they need to feel to send for transplant. So I think this is a key point that we need to see, that this again translates to the overall data that we have, that about 10 to 20% of the overall population that is seen would be requiring a transplant. So some of the general awareness questions that are there, we ask that, is liver transplant becoming a successful procedure nowadays? And that's a unanimous yes. Which type is more common in India? LDLT. It was nice to see that it was responded across the subgroups. Scoring systems that are there, people do follow a scoring system. About 91% said that yes, there is a specific scoring system that we use, out of which mostly responded by saying MEL or in combination with child class, and around 20% said about general performance status. If we see the ACLF groups, there was hardly any responses of utility of the two primary criteria, the CLIF scores and the ARC scores that were there. I think we missed out on putting out on the ALF transplant criteria, which I think we need to tweak it a little bit for continuation of the survey. Nextly, I think we were discussing in this a part of this as to, of all the patients who deserve an LT, how many deny it only on ground of finances? Like they have their donors, they have their other requisite parameters. So about 66% of them felt that more than 50% of the patients that they see deny it only because of lack of finances. And this was not different between gastroenterologists, hepatologists, and physicians. The respondents were quite similar. So which groups, as we were discussing, that what are the indications for transplant and when we should be selecting it? This is, I think, quite in sync with the literature that's there. Acute and chronic liver failure, acute liver failure, decompensated cirrhosis. And nice to see that people have considered that HCC, where a chunk of HCCs goes to oncologists many a time, but there is an awareness that HCC needs to be sent for transplants. And what is the complication? I think Ashok sir brilliantly showed that side, that how different types of decompensations have got different perspectives of overall survival. So this is something that we need to indicate. What's impressive is only 11% said that bleeding would be leading to a transplant that you would be immediately considering, while the numbers go higher for encephalopathy, HRS, HCC, and ascites. So this again, I think it's a translation of what studies say into practical purpose. I think we need to focus. I think we can discuss this later, because bleeds may sometimes be in non-cirrhotics, where when physicians see them, they can be non-cirrhotics whose natural course of history may be quite different. I think that's for something that we can discuss about. When do we consider that it's not suitable? So here we got a different sort of responses. Poor performance status, around 64%, advanced malignancy, 76%, multi-organ failures with or without sepsis, again 76%. So this is again in sync with what the guidelines say as to which patients you should not be taking up for transplant, which is primarily who have advanced sepsis, advanced disseminated malignancies, as well as those who are having MOFs with or without ventilation support. Again, I think we were referring to this in the talk for some time, that what are your common concerns that you face when you decide to refer a patient for transplant? And it was 90% is finances. But then again, there is an availability of donor issues. There are things that we need to discuss as to how proactive people are as to search for donors. And then again, as Akash sir was mentioning, that lack of understanding of the disease and fear of poor transplant outcomes. These are also things that we are possibly where more awareness gathering is required. Post-transplant awareness amongst GI-HEP as well as the other subgroups. So chances of rejection, this is nice to see actually 64% do actually feel that it's lower than other transplant, which is true. The chances of rejections in liver transplant are actually lower than what conventional kidney transplants are or the other transplants. And what's again nice to see that the subgroup, though there was a majority who had responded that they do not have lack of knowledge, they do have lack of knowledge. But again, the ones who had responded, the primary response was that it's lower than other transplants. Infection after transplant, it's about 80% said that it's somewhat higher, and it was also similar if we take out the GI-HEP part, and among the physicians that they also feel that it's somewhat higher, but it's not extremely high in comparison to a routine care. Quality of life, I think this is something which is very much important, and there is a unanimity among specialists as well as physicians in this, that the quality of life is something which drives somebody to go for transplant. This is something which cannot be taken out from any of the transplant benefit that's occurred. And about post-transplant immunosuppression, again, something which we're hitting on in the talk. How long do we have to consider? This is a common question that patients, physicians, everybody is concerned about, that how long the patient is going to be on medicines. So about 64% said lifelong, but that's what's important to mention is that lifelong may be just a pill a day, and that's not much when you think about the non-transplant costs that are to be incurred. The last question that we asked is that about alcohol abstinence and transplant. Alcohol, along with NASH, is going to be in the NASH population, is aged, difficult to transplant. So alcohol is possibly going to be the main driver of transplants in the years to come. There is no unanimity among them. We know the 6-month rule has been challenged in the ACLF setting, but still holds true. So around 40% still say 6 months, 3 months about 30.8%. This is interesting that 15.4% says no abstinence is required as it's a life-saving procedure. So I think with that, we come to a closure. I think there were interesting responses. We need to tweak our surveys more and make it more streamlined. And I think we can do that in the next efforts that we take up. Now, thank you, everybody. And I think we can again open up for discussion.
Thank you, Dr. Akash. Very nicely conducted survey. But I think I'll need input from Dr. Akash as well as from Dr. Acharya sir also. How we can go for some better surveys. So now we have discussing that it is the common concern that can make a formulation or help in making guidelines. So I think this is also become a little difficult. We can make much simpler way of proper merge, and this will add value to the GLAD, and we can go for common topics, and we can make this. So any suggestions or guidance, Akash Shukla sir?
No, I think brilliant job, Akash. I think you have done a fantastic survey, and it does give real insights. And I think we need many of these for even other topics to understand what are the barriers in delivery of the healthcare, because very often we focus only on the scientific contents and we forget the patient perspective and the patient needs. And I think this is what is extremely important. Similarly, unless the entire medical fraternity at every level of care, whether it is tertiary care, secondary care, or primary care, is in sync and is talking the same language and the same tone, you cannot expect the patients to get better, or to do a large level service to the community. Because if there are discordant voices at primary, secondary, and tertiary care, then there will be a huge discrepancy in the delivery of healthcare. And it is the duty of the tertiary care people to ensure that they handhold and guide the secondary and the primary care level people to whatever extent possible, so that most patients are taken care of at that level, and only those who really need the tertiary care are referred to the tertiary care, and that too at an appropriate time. I think that is what should be the goal. And to understand the barriers for such execution, I think we need to have such surveys for every topic that we are doing. So I think brilliant job, Akash. We must be congratulated. And I think these things should be converted into publications as well. Because it takes a lot of efforts to organize these. So I think you should take advantage of this and publish it, because it will help a wider readership to understand what are the ground realities and what are the problems.
Thank you, sir. So I think Dr. Divya is here with us, Dr. Girish Pati. We request you both of us, being our esteemed panels, for any suggestions or anything you want to share for the our all esteemed audience. So Dr. Divya, one more thing, people feel that if I'll go to Dr. Divya and he will tell transplant, so they try to avoid. So that is a common physician's feeling as a gastroenterologist, hepatologist, or even a general practitioner also. So they want to delay the transplant. What is your say on this?
So actually, when I was initially managing the patient, I thought that medical management may be sufficiently prolong the life. But overall, when I gradually understand the disease process, understand the various decompensation, then I realized that actually transplant is needed to improve the quality of the survival and prolong the duration of the survival. Another thing which I want, can you hear?
Yes, sir.
Yeah.
Another thing is, sir, the barrier to this transplantation in our country or my state. What I find, I am conducting this. I am counseling the patient relatives about what you feel about transplant, what you feel about what are the barriers, why are you transplanting. I am counseling most of the patients who are sick patients, including decompensated cirrhosis or patients with acute and chronic liver failure. They are telling, majority of them are thinking that there is something will happen to the donor. That is the one of the major issue. Will the donor remain safe all throughout her life, or something happen to the donor? That is the most important issue, and that has not been addressed, I think, in this survey. That is what I want to tell. Actually, donor issue. Everybody, the donor is absolutely healthy. Nobody wants the donor to get affected because of this transplantation. That is the thing I think it should have been included in the survey. And donor complication obviously occur, and donor is not getting anything from transplantation. There is no prolongation of life of donor or any physiological advantage to the donor after donating the liver. There are documented complications, including mortality after donating a liver. So that is one thing I think should be included in this survey.
Thank you, Dr. Dr. Girish, one more thing, that most of the, because you are the head of the department also dealing with students, so they need a transplant exposure as a students of hepatology or gastroenterology. That is one. Two, as the MBBS or MD students, they should also little bit need to know on this, so that I think what we're discussing, Dr. Akash and Professor Acharya, there's a lot of fear with the public. But at the same time, as a primary care breeze, we can alleviate most of this. So what is your take on this to make the awareness on transplant and outcomes among the medical students beginning from the MD or MBBS, definitely for the gastro students. How you think the way forward should be?
Yeah, definitely. Actually, two things is my concern. One thing is lot of cases of liver disease, usually chronic liver, they suffer from alcoholic liver disease. And most of the insurance company, except government based, they usually deny to provide any healthcare facility if they are alcoholic. They have history of chronic regular alcohol use. So that should be taken care of. And another thing is what you have rightly said, the awareness. Usually there is a phobia. Usually we have also collected the information from the patient and attendant. They usually, one is the financial issues, second is the non-availability of the donor, and third is they are very much apprehensive. What will happen them immediately? They usually don't think regarding the long-term, secular long-term outcome. They usually think of the short-term outcome. Regarding what you have already told regarding the MBBS students, PG students, and even if the postgraduate students, lot of them usually not aware regarding the liver transplantation, how the cases should be selected, at what time they should be referred. So definitely awareness should be built up by going for this type of webinars, different type of physicians meet in persons, and definitely awareness all over. I would feel that definitely the community level awareness involving the government sector, private sectors, and definitely media, that is required to have a better outcome, and definitely better that every patient and their attendant and even students, primary care physicians, they should go for early liver transplantation referral. So that is my suggestion.
Thank you. So with this, I think with permission from Acharya sir, we are going to close the session. And it is a very nice discussion, very thoughtful discussions. Sir, we are going to come up with this newsletter soon. And Dr. Anand is taking part of that. So we'll share the newsletter on what we discussed today. And it will circulate to all our nearly 6,000 people who have been registered as a part of GLAD for this. And at the same time, sir, I will want to inform that next month we are going to have a talk on very practical topic, how to approach to constipation as a physician's perspective. Professor B.D. Goswami will do the presentations on 4th Friday, same time, 8:30. So we'll request everyone to keep your things ready. And also at the same time, I will request Akash to make a pro forma also. So we'll get some input. And this is our submission for this. And with this, we are going to close the session, the GLAD 6 today. Thank you.
Thank you. Thank you.
Thank you. Bye-bye.
You can make it stop recording. We'll have a little bit discussion.
Recording
Stop recording.
stopped.
Stop, make it stop and stop the live. Sir,